My talk today is the high flow nasal cannula. Is it useful? Is it always indicated? When we deliver oxygen, we have indeed, in general, various systems. The most used is simple face mask, Venturi mask, high concentration, or nasal cannula. But all these, apart from Venturi mask, were probably shouldn't be not entirely correct, define it as a low flow system, because it may reach also flows that are in between 20 and 30 liters per minute. But these low flow systems, the VO2 is highly dependent on the flow of CO2 and the patient inspiration flow and breathing pattern, which may represent a problem. Indeed, as soon as the patient has a very deep swing and its peak inspiratory rate may reach 1 or 2 liters per second, which means 60 liters per minute, or even much more, this may create a problem in terms of stability of FiO2, because by using a Venturi mask, for example, the amount of air that is literally sucked by the patient during his high peak inspiratory flow may dilute the level of oxygen, and having a final setup of the FiO2, which may be different from the one that we believe are delivering to the patient. A narrative review that has been published recently in 2020 show the major characteristic of the high flow oxygen therapy that indeed are capable to deliver inspire gases above 50, 55, 60 liters per minute, up to 60. And the new turbine devices may reach also 70 liters per minute. And where the increase of flow, the higher is flow, the higher is the effect in terms of expiratory flow or limitation, a sort of break, increasing the airway pressure, and increasing for this reason the end expiratory lung volume with a better recruitment and improvement of lung compliance. A more stable FiO2 guarantees a better PaO2. All these different elements, together with the dead space washout related to the turbulence of the flow and the consequent better CO2 clearance, have as a final results a decrease of the respiratory drive, a decrease of the respiratory rate, a decrease of the work of breathing, and the respiratory effort, ultimately translated also in a better comfort. Interestingly, it is important to remind that the generation of small amount of PEEP, in general something in between 2 and 4 centimeters of water, is proportional to the amount of flow delivered to the system. The higher is the flow, the higher is the level of PEEP generated when the patient is capable to keep his or her mouth closed, generating a sort of closed system. In the same review, the authors proposed a kind of score, the rate of pulse oximetry over VO2 to respiratory rate, with the possibility of coining this ROX index and the opportunity of just evaluating this index at the various moments of the application of the technique. And for each moment, considering various options for the prosecution or interruption of the therapy, depending upon the severity or the higher or lower level of the ROX index. For example, if a patient after 2 hours of the high flow oxygen therapy has a ROX index in between 2.85 and 4.87, you may increase the support or evaluate after 30 minutes. But this possibility of checking and rechecking offers the possibility of modulate the intervention depending upon the response of the patient. Looking at the conference reports and the expert panel, we know that the role of high oxygen nasal cannula as a respiratory support strategy in adult translated into a strong recommendation when this can be used in hypoxemic respiratory failure, or a conditional recommendation when we should look at the phase post-extubation. On the postoperative use of high-flow nasal cannula in high-risk and obese patient is a conditional recommendation and no recommendation at all in peri-intubation period. One of the first studies that has been published so far concerning the high-flow randomized trial was the one that came in from our group. The first author is Rino Maggiore, where the high flow was compared to the Venturi mask after the extubation in patient developed acute respiratory failure, post-extubation respiratory failure. This is the flow chart, the distribution of the patient, and looking at the oxygen saturation, the respiratory rate, and PF, you immediately realize that when you use the high flow nasal cannula, the outcome is better in terms of the three parameters over time. And also the comfort was certainly increased once again over the time when we compare to the oxygenal therapy. The number of intubation in this group was lower. Certainly, one of the most popular paper published on the comparison of high-flow oxygen therapy or nasal cannula to the other techniques is the study coming from Jean-Pierre Frat and the Florali group published in France, and where they enrolled a number of severe patients, all of them having a very low PF below 200, so patient with acute respiratory failure in severe conditions, and where looking at the cumulative incidence of intubation, there was no difference, but for those patients who had a PF below 200, there was a significant difference in favor of the use of high flow oxygen in comparison to the non-invasive ventilation. But even more, there was a significant difference in terms of mortality rate in patients who received non-invasive ventilation in comparison to the high flow oxygen, even though the vast majority, if not all, the deaths were due to the occurrence of circulatory shock that has indeed a very faint or inexistent relationship with the use of a non-invasive device. Looking at the critical appraisal of this study, some of the final results can be criticized because, for instance, the non-invasive ventilation was applied intermittently and not continuously without any standardized protocol. And the experience of the various centers participating in the study was indeed unbalanced. There was a crossover. Finally, there weren't clear-cut definitions for the intubation. And probably the inability or applying the non-invasive technique properly translated also in a delay on intubation. Moving to a different setting, looking at the moment of the peri-intubation moment in hypoxemic patient, comparing the high-flow nasal cannula to the high FiO2 fashion mask, these investigators, once again coming from France, compare in a random infusion during the perioperative period for the endotracheal intubation procedure, and they showed that there was at the very end no major difference in terms of the lowest SpO2 during the endotracheal intubation procedure between the two groups. Interestingly, the group of Elia Zoulet and Alexandre Moore published a paper where compare in immunocompromised patient with acute respiratory failure the high flow oxygen versus standard oxygen on the 28-day mortality. They randomized a consistent number of patients in the two groups, and the final outcome was no difference between the two groups. In presence of acute respiratory failure, the number of deaths that were recorded in the high flow oxygen therapy group and the standard oxygen therapy group were not different. And there was only a trend in a better, in a shorter length of stay in the ICU for those receiving standard oxygen. And the overall mortality probability was absolutely comparable between the two groups. Even though for those patients who were affected with hematological malignancies and were more severe, apparently the use of the non-invasive ventilation, also with the helmet, was beneficial. Looking at the high flow nasal therapy in immunocompromised patients, evaluating a number of studies through a systematic review and meta-analysis published recently in 2019, the authors showed that there was indeed no real benefit in favor of high flow nasal therapy. You can see that the diamond is across the line of identity, and there was a trend, especially in some of these studies, and the most favorable trend was in the FRAT study. One interesting possibility is represented by the capability of asking the patient on respiratory, spontaneous respiratory breathing, assume the awake prone positioning while breathing through the high flow nasal oxygen. And in this study was indeed adopted this technique with the intent of improving the final outcome, comparing the high flow plus the awake prone positioning between high flow and high flow alone. And the final conclusion in terms of analysis of the intubation rate did not show any difference, and the awake prone positioning did not reduce the need of intubation. So, despite the negativity of this trial, nonetheless, one may conclude that also under this condition, when we ask the patient spontaneously breathing to assume and to put his position or her position prone, may be feasible. These are the lack of difference between the two groups. At this point, which are my conclusion, that we do have data that suggest an effective method for delivering therapy after extubation, to some extent, maybe also very useful, certainly better than Venturi or the classical oxygen therapy. And looking at some subpopulations, these differences may be relevant and certainly safer than a Venturi mask, with one of the things that is often occurring is the displacement of the Venturi mask for intolerance, while receiving a normal temperature and humidity through the high flow may translate into a better tolerance on part of the patient. And at the very end, some of the study demonstrated that high flow nasal cannula can be, at least in the early phases of the acute respiratory failure, comparable to the non-invasive ventilation, especially when the non-invasive ventilation in mask in pressure support mode has been used. Once again, I thank you for your kind attention.